I don't think so. Nadine, anything you need or?
No, I'm great. Thank you.
Great. Cup of coffee.
I wish, right?
Should I get closer?
It's 9 o'clock.
Renee, oh, I need to turn that off. Should I get closer, or is this okay?
No, you're perfect. You're perfect.
Hmm.
All right, are we ready to start, Gina?
Yeah.
Okay, great. Well, welcome everyone. You're joining us for the CHCF Alumni Network Fall event, which is sponsored by the California Healthcare Foundation and administered by Health Force Center at UCSF. We are grateful to have Dr. Nadine Burke Harris here with us this morning for our opening keynote. A couple of technical things before we get into the session. All participants are on mute to ensure that we can hear the speakers. We encourage you to write your questions in the chat. We will invite questions at various times throughout the session and have an open Q&A at the end. Thank you for joining us, and I will now hand it over to CHCF Alumni Board President, Maria Ureña.
Thank you so much, Renee, and everyone. Welcome. It is my sincere pleasure to welcome you to this year's California Healthcare Foundation's Leadership Program's Fall Alumni event and Cohort 18's graduation. So big round of applause for that. A couple of housekeeping items, just like Renee said, please mute yourself so that we can avoid distractions during the very inspirational, important sessions. And then, of course, if you do have questions, put them in the chat. So just a quick note on who the Alumni Network is. We are over 500 members strong who graduated from the CHCF Healthcare Leadership Program. Every 2 years, the Alumni Board sets strategic priorities that guide the work of the network. On your screen, you will see the 3 initiatives that were chosen as priorities through the end of 2021. So for Build and Sustain the Network, which you see on the screen, we are creating events like these that help us come together to learn and engage, and are grateful to have a team of staff who provide administrative support to help us achieve our priorities. For increasing network influence, by supporting members' ability to be influencers and thought leaders and increasing the visibility of the network, and a way for those beyond the network to access the content experts. Sorry, everyone. To advance knowledge, conversation, and action across California. And the next one, Act to Improve Health, by coming together. How we're doing this is we're doing this by coming together to take collective action and achieve a desired outcome. So today's session, being a prime example of this point, and we look at how we can improve care by identifying actionable solutions. Next slide. So the seminar over the next 2 days is an opportunity for us to engage with each other, commit to changing ourselves and our systems to improve healthcare for all Californians. It is titled A Hopeful Future, with the goal that the thought leaders we have invited to share with us and engage in dialogue will leave us with inspiration and a glide path to continue doing important work, to advance health across sectors, communities, and of course, systems. Here, you will see our high-level agenda with themes focusing on childhood trauma, systemic racism, pandemic response, and policy to support response of pandemic and understand ways that alumni can have more influence in these arenas. We also have the opportunity to celebrate again Cohort 18, who will share their chips, the work that they have championed over the last 2 years, and we'll have a graduation celebration for them to round out our event today. So really excited about that. We're grateful for all of the speakers who have agreed to share their knowledge, their experiences, and as we learn and engage in dialogue with these inspirational, unapologetic, and thoughtful leaders, I'm very excited to hear them. Over the next 2 days, please reference the alumni website at the tiny URL that you see on the top there to view the full agenda and the speakers. Now, without further ado, next slide, please. Without further ado, I am very excited and very grateful to announce our opening session in which we invite Dr. Nadine Burke Harris Surgeon General of California, to talk in conversation with Keynote Allen, our Alumni Board past president. Keynote, I hand the mic to you. Welcome.
Maria, thank you, thank you. Nadine, good morning, thank you. Quite the thing. Want to really say thank you for taking the time to chat. And I see you're without your cup of coffee, and so am I. So this will be really interesting, right? There are over 100 alumni on this call today, and you are our inaugural speaker. So thank you. We're excited. This is our kickoff. I'm excited to also have a chance to hear how you've really integrated your life experiences to bear on the way that you lead. After reading your book, love the book, The Deepest Well. This is a pitch, people, so if you haven't read it, it's an incredible book that really talks about things that we've all probably started to put pieces together, tried to connect the dots and haven't quite gotten there. And the book puts it all together for us. And you're going to talk about that this morning. But I really, really enjoyed reading how you pulled from your whole life, your father's inquisitive style, making paper airplanes, Tyrone's tadpoles, how you led your team to build, and how you even got to build Bayview, Hunters Point Clinic, how you've developed ACEs through that work there, which is really our focus today, and how you've come to the Center for Youth Wellness. And now you're the first Surgeon General for the state of California. I mean, all of that leadership journey is incredible. And throughout that, I think through the book, I really got from you the threads of positive relationships, the positive mentors that have allowed you to bring out really positive outcomes. So I'm just thrilled to hear your story and hear about, this year of 2020 has been a rough and traumatic year for everyone. And I look at you as kind of that, mother of all these children and how to raise them. And this is really a time that we want to hear about how these adverse childhood events, really how we as the alumni can make a bigger and better impact on the care that we provide our kids to make a better future, which I know is what you're about. So in all of that and all of my talk, it's time for me to let you talk. And could you start telling us about your leadership journey and where are you today, how you got to be where you are today, and were you vulnerable? Were you persistent? Were you, was it okay to fail? All of those great things, Can you lead us through that?
Yeah, absolutely. I think it was a little bit of all of the above. When I think about that question of my leadership journey, when there's one scene that I actually describe in my book that you'll probably recognize, which was when I first started learning about adverse childhood experiences and the profound impact that they have on health over the life course, right? Like not only in childhood, but over the life course. I was really deep into it because I had spent, I think like many folks who are on, with us today, I had spent my medical school, I did my MPH, my residency, and being in clinical practice. And my whole focus had been, wanting to heal communities and trying to better understand how we can do a better job serving the most vulnerable, and how do we kind of break the cycle. And so when I read about ACEs, it was, kind of this mind-blowing experience to recognize that early adversity not only impacts risk of the things that I felt like I recognize intuitively in terms of mental health concerns and behavioral concerns and, risk of substance use and other things, but that, it affected my patients' risk of heart disease and stroke and cancer and asthma and diabetes. That for me was pretty mind-blowing. And that really put this issue of early adversity squarely in the realm of healthcare, right? Like it's not just, social services consult and then I'll see you later. Like this really was my job. And so there was this moment that I describe in the book where I took I went to the hospital council, which was, all of the hospital CEOs in the Bay Area. And I had my PowerPoint slides and I was ready, and I was going to sound the alarm. I was going to tell the powers that be, and they were going to fix it, right? So I did my presentation. I was so well prepared. And at the end, I said, here it is. What are you going to do about it? And I'll never forget that moment of them looking back at me and saying, essentially, Nadine, we believe you. We think it's important. So what are you going to do about it? Right? And the fact that they didn't have the answers was so, I felt like, wait a minute. How is this problem going to get solved? Because they were going to solve the problem, and now I'm hearing from them that they don't have the answers. And I was so deflated by that. And then the thing that happened that really was the game changer, it really was a transformative moment for me, was walking out of that room. And as I walked to the elevator, the woman who had been serving coffee for all of the hospital CEOs, she followed me out and she stopped me on the way to the elevator. And what she said was, I heard everything that you were saying, and I myself, I think I have 10 out of 10 of those ACEs that you were talking about. And it just makes so much sense. It helps me understand what's been going on with me. I've struggled with my sobriety. I've had lots of health problems. And she said, I just want to tell you, keep doing what you're doing. And that moment for me, I think, was a really powerful one, because I don't know that when I started out on this journey, which it really, it is a journey, that I knew where I was going. I don't know that I said, hey, I'm going to be out there and I'm going to be this champion for this issue. What I knew was I was seeing every day how it was affecting my patients. And I kept on hearing reinforcement along the way from people who were saying, we need you to keep going. We need you to keep doing what you're doing. And that really was the huge, powerful motivator for me. And then in terms of bringing all the pieces of my life into the work and bringing my whole self into it, I think that's just, generally speaking, I think the more that we show up with authenticity and joy and just show up with who we are, I think we tend to be more successful. I don't know any other way to be. So yes, that's definitely been my leadership journey.
That's fantastic. And that's really interesting that you say that, just show up to who you are and be authentic, because that's exactly what I've heard, is that, what you see is what you get with Nadine. That is her all the way.
That is true. For better or for worse.
Aren't we all, though, right? We're all there. We've got over 500 of us that are everywhere from CEOs through frontline. We actually get to touch the patient still and take care of that patient. A lot of us here, we're podiatrists, surgeons, physicians, pharmacists, dentists, social workers, nurses, all of us. And I hope I haven't left anybody out. But help us understand the great science that's gone in behind this, because I think I personally had a misperception of this is for kids that live in the barrio. This is for kids that live in South Central LA. And in learning about where Bayview sits, I think, oh yeah, it just reinforced to me, this is who it is. So can you walk us through the science of it, so that when we go out and we understand this better, we can be more of a champion, understanding the deep science that's really gone into the work. So can you tell us about that?
Sure. Yeah. I mean, I think that part of the reason why the ACE study that was conducted by the CDC and Kaiser Permanente now more than 20 years ago right? Part of the reason why it was so groundbreaking, and part of the reason why it's been such a very useful tool for me, not just in terms of the epidemiology, but also as a policy tool, is because the study that the original adverse childhood experiences study, right, where they asked 17,500 individuals about their history of experiencing any of 10 categories of adverse childhood experiences, which include physical, emotional, or sexual abuse, physical or emotional neglect, or growing up in a household where a parent was mentally ill, substance dependent, incarcerated, where there was parental separation or divorce, or domestic violence, right? The thing that was so powerful about that, right, was number one, the fact that they found that ACEs were so common, with 2/3 of folks experiencing at least one of those categories of ACEs, 1 in 8 folks experiencing 4 or more. And the piece that was really powerful about it was that it wasn't in the barrio. It wasn't in a low income, Black and brown or a historically disenfranchised community. It was in Kaiser, San Diego. It was 70% Caucasian, 70% college educated. These were folks who were all members of Kaiser, right? So they all had healthcare access. But what they found was that not only were ACEs common, but also there was this dose-response relationship, not only between some of the things that we intuitively would think of, like mental health concerns, depression, anxiety, suicidality, right? But also behavioral health concerns in terms of substance use and dependence, early onset of use, increased risk of relapse. But there was this really strong dose-response relationship between ACEs and the leading causes of death in the United States, heart disease, right? And it wasn't a small association, right? For someone who had 4 or more ACEs, the relative risk of ischemic heart disease was more than double that of someone who had 0 ACEs, right? For stroke, it was 2.5 times. For chronic lung disease, it was triple. And so when we look, even looking at the association between ACEs and Alzheimer's, right? This very, very strong association with things that we hadn't really thought of before. And for me, the thing that was exciting about it is because, as you mentioned before, my dad is a scientist, my dad is a biochemist. I was really raised from a very, very early age to look at the world through a molecular lens, right? So when if there was milk that spoiled in the fridge, or if I got a curry stain on my blouse that changed from yellow to pink when I touched it with a bar of soap, right? My dad would be the first one, oh, curry is an acid-base indicator, right? So I always really, the first thing in my mind always was really, I wonder what's behind that. I wonder what's the molecular mechanism behind that. And now, in the past several decades, we have a much deeper understanding about how these repeated exposures to adversity, it activates the stress response, and how this repeated activation of the stress response, especially during the critical and sensitive periods of childhood development, right? And when we're talking about critical and sensitive periods, we're talking about times of enhanced neuroplasticity, where our experiences really become wired in terms of the ways our neurons talk to each other, right? And so what we see is that when we experience high doses of adversity in childhood, we see not only long-term changes in brain structure and function, but we also see changes to the structure and function of the developing hormonal system, the developing immune system, and even the way our DNA is read and transcribed. And so for me, I was like, oh, that's medicine. That's squarely in my purview. And once we understand those mechanisms, then we can use that science to interrupt those mechanisms. So that was really, I think, why the science of ACEs and toxic stress, I think, has been so powerful, because there's such a strong underlying driver of so many of the not only healthcare, but also social challenges that we see in our society.
Yeah, and there's a lot more study going on, and I know that you're continuing to study, so appreciate that work. And just a small story is in seeing what you talk about. We had a 4-year-old little boy that came in, probably about 55 pounds, minor burn, and he decided to tear the cabinet doors off of our ICU. 4 years old. And as we found out, as we got to know this little boy, and his care worker came in, caseworker, he had been kidnapped the year before, and they don't know what had happened to him. And in doing that, I pulled your book out and the learnings we had, and our social workers who are trained with ACEs in mind. And the nurses sat down, instead of saying he's a really recalcitrant kid, he's just horrible, and what are we going to do with him? Take the bed out, remove everything. They actually turned around and sat down and hugged this little boy and held him in the bear hug that they're taught. And we watched this little boy over a week start to relax with us and start to gain a little bit of trust, maybe. But all of that had changed from what we as nurses had been, what are our options to do no harm? And it's take the beds out, move everything out, but nothing about reaching this kid's heart and understanding he had been kidnapped. He was 4 years old. He had no way to tell us what had happened. We didn't know how to heal him. So it's a day-to-day thing. And I think many of us are struggling with that in our professions. And I thank you. In fact, that kind of leads me to a lot of work that you did that kicked off this as a special little boy that you've watched grow up, Diego. And to put in context that science, can you tell us Diego's story of what you've watched when he was little, all to where he is today as I think a teenager? Yeah. And he's doing well.
Yeah. So this was definitely one of the central stories that I was grateful to have permission to share in my book. And it really was, Diego really was one of my patients that brought this home to me and really opened my eyes to how important understanding the science was. When I first met him, he was 7 years old, adorable little kid who was in my waiting room, waiting for me in the exam room, and was there for a physical exam. And when I went in to see him, his mom had brought him in because the school nurse was concerned that he had ADHD, attention deficit hyperactivity disorder, and wanted to understand whether he needed Ritalin because he was having, behavior that was difficult to manage in the classroom. And, but what I noticed when I did his physical exam was that he was itty bitty. In fact, when I plotted his growth curve, even though he was 7 years old, his height was the 50th percentile for a 4-year-old. And when I started asking his mom about when his behavioral problems started, and just getting into my normal history like we're trained to do, she started to cry. And so I had Diego and his sister escorted out of the room by one of our medical assistants to play in our waiting room. And his mom told me the story that when he was 4 years old, he was sexually assaulted by a family friend who was living with them. And what was really powerful about it was, as I was looking at him, he had asthma, he had eczema, he had behavioral concerns. But he also really strikingly, when I went back and looked at his old growth charts, it looked like he had a growth arrest. and at age 4. And I, you know, I did in treating that patient, I did all the usual things that I was supposed to do, you know, in terms of treating the asthma with medications and the eczema. And when I was consulting with the endocrinologist about the growth arrest, you know, I said, let me ask you this question. I know this seems crazy, but is it possible that the fact that it seems like he stopped growing at age 4, could that be related to this terrible trauma? And she said, no, that's not crazy at all. You know, that we've seen this happen. And yes, this type of trauma could lead to a growth arrest. And for me, that was one of the many kind of experiences that I had with patients that made me want to take a deeper dive into the science of how early adversity affects the developing brains and bodies of children. But, you know, I want to tell you, I think people, after reading my book, often ask about the story of Diego. And we really, you know, he got family therapy. We followed him through the years. We were able to recognize early when, for example, after his family's home, their apartment had, you know, it's like substandard apartment, faulty wiring, ended up, there was a fire in their apartment. And so his family ended up being homeless. And what was interesting is that when he came into my office, he didn't say anything about the fire. That's not true. He didn't say anything about being homeless. What he said was there was a fire. He was having a real severe asthma exacerbation. And I had him on steroids and, you know, really strong medications. And every time he came back, it seemed like the steroids just weren't working. And finally, as I was sitting down and I was asking, you know, doing a deeper dive with the family, it turned out they were homeless. He was sleeping on the street with his mom and his little brother, and he was terrified. And when we were able, through a social worker, to get them connected to supportive housing, it was only then that it really seemed like his asthma improved. And one of you know, so over the years, it's been wonderful. We've had a very close relationship. It's been wonderful to follow him and see how well he's done. But the thing about that story is it was really hard. I think it was really hard for them. It was really hard for us in our clinic to, you know, the first time I saw him, I was kind of scrambling. I was trying to pull the pieces together and figure out, how do I help this child? And for me, the big takeaway from that is that in our clinic, once we started systematically screening for adverse childhood experiences, what that required us to do was put into place the resources, the protocols, the handoffs to be able to manage these things as they came up. And so, you know, years later, after I founded the Center for Youth Wellness and we had these, you know, multidisciplinary teams and we were routinely screening for ACEs, it was so much easier, right? The first time I saw Diego, it was like, I as a provider was like, oh my God, what do I do with all this stuff? I've got his, you know, his growth problems. I've got his asthma. I've got his, you know, family, emotional issues. You know, how do I deal with all of this stuff? And by the time we got to the point where I had been seeing Diego for a number of years, it was like clockwork. You know, we had all of these resources down, and I think it really led to much improved outcomes. And I think that's the piece that's really the big takeaway for me. It's not the individual patient, it's what is the ability of our systems to respond to these things when they come up, right? In a way that's not overwhelming for the patient or for the provider.
Absolutely, a lot of infrastructure, a lot of work to put it together. Yeah,
Mm-hmm.
and I know that there's some great questions that are out there right now, and I know Renee's been aggregating them because it's just lighting up, Nadine. There's all kinds of questions, so
Yeah,
thank
there
you.
are lots of amazing questions. I'm going to do my best to try to consolidate and bring them forward. So some questions around how do you see ACEs for marginalized and minority communities with things like police brutality? How have you seen the pandemic and things such as, kids working and trying to go to school from home impacting this? Public health is sort of blowing up now with the pandemic. And so how do, ACEs is a public health issue, and how do you suggest public health leaders might deal with that? And then another question around mental health referrals. So, right, this is all, like, what do providers do about all those kinds of things, and what are your ideas?
Yeah, so my answer to the first question is, one of the things, so I think I've mentioned that I am a super hardcore science nerd, right? And one of the things that I think is really important, and actually I will tell the story behind this. So I had a chance to meet with Dr. Eric Gooseby, who was the AIDS czar for the U.S. and really he's right now is at UCSF, I think, still at the Center for Global Health. But as I was trying to do this work on ACEs and toxic stress, I asked him, I said, hey, listen, how did you guys develop antiretrovirals, right? Because he led the multi-site teams that developed antiretrovirals. I was like, how'd you do it? Because that's like, when I think about one of the biggest public health, advances in the past, 40 years, our response to HIV/AIDS and dramatically dropping the death rate was huge. And as he walked me through the process, one of the things that he emphasized was the importance of rigor, right? So they had, for example, all of these, AIDS defining conditions. And he said, one of the important things is to figure out, to parse the apples from the oranges, to really understand what are we dealing with in terms of which of these factors are actually a risk factor for HIV/AIDS, which of these health conditions are actually AIDS-defining diseases, and that helped them do a much better job in refining their treatments. And when it comes to ACEs and toxic stress, right, one of the things that's really important is that we have that same level of rigor, right? So what we know is that when we take the 10 traditional ACEs, we know that we have data from hundreds of thousands of individuals, right? We have population-based studies both in the US and in more than 20 countries around the world that tell us, okay, if you have an ACE score of 4, your relative risk of ischemic heart disease is roughly 2.1, 2.2, right? And we know that that's using the 10 traditional criteria from the CDC Kaiser study. And the question is, what happens when we use other criteria? Like, how does that affect the relative risk of disease? Do these other criteria also activate the toxic stress response, right? That those long-term changes to the stress response that lead to neuroendocrine, immune, and genetic regulatory disruption. And that's the piece where, for example, so I'm very careful and cautious. I try to be very rigorous in being clear that when we're talking about ACEs, we're talking about the criteria from the ACE study. And then when we're talking about other factors like exposure to discrimination, like exposure to poverty, that we understand that these are risk factors for toxic stress, because we've seen that there's strong evidence that these factors also can lead to a dysregulated stress response that leads to neuroendocrine, immune, and genetic regulatory disruption. And I think that when we think about the toxic stress response and looking at the interventions to address the toxic stress response, we recognize that we have to take this public health approach. And this public health approach goes all the way from our policies, right? Like paid family leave that the governor just, strengthened the support for paid family leave in California. To these systemic and structural factors, right? All the way to cross-sector education, right? Like, how do we respond? For example, just like what you talked about earlier around a child coming in to your center and tearing the cabinets off of the doors off of the cabinets, right? Like, how do we respond? How do we train not only our healthcare providers, but educators, early childhood workers, law enforcement, right? Everyone across the board, just as we all know that microbes cause infection, right? And that influences how we do everything day to day, right? So we're all wearing masks right now because we understand about, transmission of COVID, coronavirus. Similarly, understanding that high doses of early adversity lead to these long-term changes. What does that mean about how we all need to respond differently? So there's that cross-sector work. And I think it goes all the way from the cross-sector work to, routine screening, clinical response with trauma-informed care, all the way down to research around, what is our potential to develop novel therapeutics that help to regulate the physiologic stress response? Just like we need both hand washing and antibiotics, right? We need both these, prevention and addressing these systemic and structural factors, and we also need, everything in between in responding to this public health crisis. One of the things that feels really important to me is that the evidence demonstrating the extent to which exposure to racism is a risk factor for toxic stress. And then similarly, and the reasons for that are very similar in terms of the mechanism by which the pandemic is also a risk factor for toxic stress, right? Because they directly increase ACEs, right? So they directly increase harmful exposures, right? Adverse exposures. They increase things like parental mental health decompensation, right? Directly increase things when you think about discrimination and mass incarceration, right? That directly, for every child whose parent is incarcerated, that child has an ACE, right? And so we see some of the way that these systematic racism and discrimination in our society directly contributes to ACEs, but it also takes away the ability of the caregiver to be a buffer to that adversity, right? So the more stress, strain, trauma the caregiver is under, the more difficult it is for them to be that buffering, secure antidote to adversity, so that it doesn't lead to these long-term changes. And so all of these things, and then they themselves, the exposures themselves, whether it's the stress of the pandemic or the ways in which interpersonal racism activates that stress response, activates that fight or flight response. These factors themselves are also independent risk factors for toxic stress, right? Like they activate the stress response themselves. And so, again, all of that requires a systemic and public health approach to addressing them. I think in terms of the last question around mental health access, I think that is a place, there are two things that I think that immediately come to mind. So one is that we have a lot of work to do when it comes to achieving parity between mental and behavioral health and, medical treatment, right? Like, the body doesn't stop at the neck, right? Like, there's no barrier right here that says, okay, everything up here and above, you get treated by this person, everything down here and below, you qualify for, a certain type of healthcare. So the body doesn't do that. We make this artificial distinction. And so we have an incredible amount of work to do to achieve parity and access to mental and behavioral health care. And at the same time, I think one of the things that's really important is also recognizing that we don't have to have, if we are waiting to have a perfect mental health system before we start doing routine screening, early detection, and early intervention for ACEs and toxic stress, there's a tremendous amount of harm that is going to happen in the meantime, right? And so I think it's important for people to recognize that mental health treatment is one intervention, but it's not the only intervention. And it shouldn't stop us from helping to do the early detection and early intervention, and especially to be able to educate our patients about the impact of ACEs, what is toxic stress, what happens when we have, all these stress hormones circulating in our body, and what can we do about it, right? I think patient education in and of itself, combined with, the things that help to mitigate the stress response, sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships, I think are really key.
That's just a little bit to do, isn't it?
Yeah, exactly.
Geez, thank you for throwing that gauntlet down. That's a great one. Renee, there was a question on racism that we wanted to pop in there.
Yeah, I mean, I think there have been some questions in the chat around how do you sort of shift the narrative around this from an individual to a systemic conversation? And, we have a group of over 100 people on this call today and over 500 in our network. If there were one thing that these clinical leaders could do, what might that be to help sort of move this conversation in a different direction?
To move the conversation about racism as a public health threat?
Yeah, and to actually improve the impact and the outcome there, I think would be the ultimate goal.
Yeah, well, I think that what we're seeing right now is that I will tell you one thing that I have really experienced myself as a leader is that racism has been a little bit of a third rail topic in our society. And it's been a little bit like, well, you can talk about racism, but don't talk about it too loud, right? And don't, the thing for me that has been the most untenable part about our society's response has been the extent to which there are many places in which it feels like there's a tacit agreement that, yeah, we know it's bad, but it's never going to change, or that's how it is, or things aren't going to be substantially different. And that's a place where I feel like there are so many folks, especially right now, especially in this moment, who are recognizing that no way, I don't agree to that anymore. It's a little bit like, I think this is something that was really powerful for me, my own personal experience of it, it's a little bit like the Me Too movement, where it's like, wait a minute, we've been going by these unwritten rules for all this time. And then all of a sudden something happens and you're just like, I'm mad as hell and I'm not taking it anymore, right? And so it's like, I think that when we're asking the question, what can we as public health leaders do? So number one, I think that we can keep insisting on this conversation and keep insisting on concrete changes, right? Not just platitudes, not just, solidarity statements. I want to see how people are walking the walk. So what does that mean in terms of your recruitment and retention? What does that mean in terms of your policies and procedures? What does that mean in terms of your outcomes, right? Because as long as our outcomes are still terrible, we're not doing a good enough job. And addressing racism as a risk factor for not only for toxic stress, but as a public health threat needs to be front and center until we are able to move those outcomes. And so that is one thing that I would encourage everyone is look at the data, right? And for me, one of the things that's been critical is really do a deep dive to understand what are the levers, right? What are the factors that are at play and how do we counteract those factors? So I could go on. I have a lot more on that, but I think that it's incredibly powerful. And I think now more than ever, I think what we are seeing is an actual threat of retrenchment when it comes to racial justice, right? Like it feels like the conversation is actually moving backwards as we have, mandates coming out of the Office of Management and Budget at the federal level saying, hey, we can't do any training about racial bias because it's un-American, right? That's like, we're really in a struggle right now.
True, absolutely, and we all got to get out and vote too. So, excuse me. Do you think, after all of this comment that you're making, do you think that the state is looking to make a statement about racism, an overall overarching statement about it? One, and two is, as we talk about ACEs in general, many years ago we had the fifth vital sign come out, along with other things that came with it. So maybe a bit controversial, but does ACEs belong as our sixth vital sign? So just the two questions.
Yeah. So I have been we are working across the administration to make a strong statement and do, and really, have the rubber meet the road when it comes to addressing racial justice. And so I think you'll see that many of our agencies have made some strong statements about racial justice. Similarly, Governor Newsom has, and we are currently right now in the middle of, pulling this together in a much more cohesive way, in a way that's not, that speaks to the moment, but it's not reactive, but is really planful around what we want to accomplish as a state in holding a larger vision for racial justice. In terms of ACEs as the sixth vital sign, I think that this is the work that we're doing right now with the ACEs Aware initiative to train our healthcare providers who care for children and adults on how to screen for ACEs, how to recognize the signs and symptoms of toxic stress, and how to respond with trauma-informed care. And so I will do a shameless plug here. Please encourage all of the providers that you work with to take the ACEs Aware training. That's at acesaware.org. one of the things I'm really proud of is that we've had over 13,000 healthcare providers take the training so far, and all of our, all of the data that we're getting back around the efficacy of the training has been really fantastic. It's been very, very high satisfaction and learning and all of that kind of stuff. But, for me, I would love for ACEs to be the 6. But the most important thing, and I think to your point, is that we're really incorporating it in the work that we're doing, both our clinical work and cross-sector.
Yeah. So I wish we had hours and hours to go, because even just talking about, some of us have children that we care for, some of us have the older ones, and all of that impact across that continuum of life. There's so much to go on. I don't want to take any more time of just me talking, but I know that we have some more questions, Renee. And so we want to make sure that people get a chance to speak and to ask you some more questions, Nadine. So Renee?
Yeah, so we've also had some questions around ACEs for adults. So how does this how could this maybe translate to that population? And if you think about ACEs as sort of like a multi-generational thing, does it get passed down by generation? So some questions around that.
Yes, so great question. So part of the reason why the Department of Healthcare Services is reimbursing providers for screening both children and adults for ACEs is 2 reasons. Number one is because it's one of our goals, right? So so coming in as our state's first Surgeon General, I'm a kind of go big or go home person. And so I've set a goal that to cut ACEs and toxic stress in half in a generation, which sounds ambitious. But when we think about the fact that in California, we've cut maternal mortality by 55% since 2006, I think we can do it, right? And so one of the ways that we do it is by interrupting vertical transmission, right? Interrupting the handing down of ACEs from parent to child. And there's 2 ways that we do that. Number one is by helping adults be aware of the fact that what they've experienced may be, but because of what they've experienced, they may have an overactive or dysregulated stress response, and that can show up in these different ways, right? Because we also know that adults who have experienced ACEs are likely to be stress sensitized and are likely to have be more sensitive physiologically to the impacts of subsequent stressors, right? So like right now we're going through the pandemic, we're going through a major economic downturn. For individuals who have high ACEs, the stress of this moment may actually have a greater physiologic impact. But the second piece of it, right, is that when we understand that, exposure to ACEs dramatically increases the risk for things like cardiovascular disease and diabetes and chronic lung disease and autoimmune disease, right? Then treating the toxic stress, right, that dysregulation of the stress response is an important part of getting better outcomes for our patients, right? So if we have patients and we're treating their intractable diabetes and that hemoglobin A1C is, it's really hard to bring it down, or we even notice that the hemoglobin A1C goes up when patients are experiencing greater hardship, right? Helping patients understand that, okay, we want to treat the diabetes, and as part of treating the diabetes, we also want to address the fact that you may be having an overactive stress response. And so we're going to double down on exercise, nutrition, sleep, mindfulness, mental health, and healthy relationships. And I'll give an example of that. I met a woman at a conference I was speaking at, and she came up to me afterwards to share with me how learning about ACEs had changed her life. And she said that she had 9 out of 10 ACEs, and that once she learned about ACEs and the impact that they had on her life, right? She was able to get out of the abusive relationship that she was in, and because she better understood some of the drivers that she had. She lost 100 pounds, and she went from being on 12 medications to being on 4 medications. And the other piece that was so powerful to me, she said, listen, I have 9 ACEs, but my 3 kids have 4, and I'm going to keep it that way. I'm going to make sure that they don't get to 9. Right? And so it's both improving our healthcare management and the efficacy of our healthcare interventions, and it's also breaking the intergenerational cycle, because not only ACEs can be handed down, but toxic stress physiology, right? Like if you look at the cord blood of babies that are born to moms who have high ACEs, right? What you see is greater likelihood of dysregulation of the cortisol receptors, and greater levels of inflammation and inflammatory markers. So both the physiology of toxic stress can be directly handed down, and the behaviors and exposures, the ACEs, can also be handed down.
Thanks, Nadine. So there's also some questions around like systemic change, right? Something small, and advancing equity. And the governor has like Props 15, 16, and 17 that are on the ballot. So there's an opportunity to vote and make a change there. And there's also like the data, right? Which you say you love that kind of stuff. So if we think about adding ACEs as something that we need to collect as part of COVID-19 data collection, sort of what do you think about those things?
Yeah, so when it comes to any pending legislation, I can't comment. So I will give you my Surgeon General line on that. But in terms of your second, but obviously voting is a very critically important way in which we can change things systemically, right? Like that, it just makes such a huge difference. When it comes to your second question around data, this is one of the things that we are looking into right now. I will say at the state level, it's not super easy to compare ACE data to COVID data, but we're working on it. This is where I'm learning in my time, my brief time as Surgeon General. I'm really learning how to get these kind of complicated behind the scenes systems to communicate and talk together and work together. And it's a little bit of a lengthy process, but it's certainly something. I mean, one of the things that we know that's part of the toxic stress response is dysregulation of the immune system, right? And we know that toxic stress is associated with increased risk of viral infections, right? And so I think that work is work that is very, very important and needs to happen. And hopefully there are many people that are part of this talk who can be part of helping to make that happen.
I know some of the people that are on the call, and I know where they work, and thinking, they've got huge, wonderful databases. I'm looking at one right now, Betsy, going, Betsy, you've got an N. So Nadine, Betsy, Nadine. Which is what a lot of this alumni is all about. The other thing that came up too is you spoke about earlier about, you learned how to do something a certain way in your public health education. You learn something a certain way within your medical education, and bringing it all together. Are there opportunities for us to change the way that we teach? There's a lot of educators that are on this call. Is there an opportunity for us to change the way we teach in order to integrate ACEs and to integrate this whole type of patient care?
Yeah, one of the things about this that I find to be fascinating is that oftentimes when we talk about ACEs, people think about it as like, how do we bring this compassionate care to the way that we teach, to healthcare, to our lens? And I think that is absolutely critically important, and it is a powerful take-home message. But I want to be clear. The science of the extent to which our experiences and environments shape our biology is so clear, right? So it's a little bit like, I feel like it's a little bit like germ theory, right? Where we're in like 1920 and we're like, how can this new science of the germ theory influence how we're teaching our medical students? You're like, it's a big deal, right? Like, this is a major driver of so many of the health outcomes that we're seeing. Like, this is the root of the root. So I definitely don't, I definitely see it in the context of incorporating this science that has emerged over the past several decades, doing a much better job in incorporating that into our medical education and our education across the board. But this is not peripheral, right? Like, when we're talking about the extent to which having, this incredibly strong dose response relationship between ACEs and 9 out of 10 of the leading causes of death in the United States, right? This is not a nice to have. This is the meat and potatoes. Like, we have to be training our healthcare providers on how to see and recognize and understand it, and how to advance interventions and outcomes,
Right.
so that we can, see public health level change.
Yeah, thank you.
Hanoi, we're at time. Do you want to ask one of the fun questions? I know, right? It just evaporated in front of us.
Like so many other questions we want to do. So we had some fun questions, Nadine, as I know that, we wanted to see what you might say to your 21-year-old self. So as of today, what would you want to tell your 21-year-old self besides, oh my God, 2020 was really interesting?
Well, okay. Can I actually answer the other fun question? If I wanted,
Okay.
if I were going to ask my 21-year-old self, what I would say is, you are enough.
Good.
Right? You are.
You want the other question? Which one?
Yes.
Do you want to answer the one of what do you think people get wrong about you?
The other one about
what do you say to yourself before you jump into the abyss and you take this huge risk?
Oh, so that's actually great. Yeah, that's fantastic. I think
you get your pick.
Yes. So the thing that I tell myself in those moments. So before I gave my TED Talk in 2014, my knees were knocking. I was absolutely terrified. And I think this is true. What happens to me every time I'm jumping in to do something scary is that right before I walked on that TED stage, and when I say my knees were knocking, I'm not saying it figuratively. My knees were literally hitting each other. And I just closed my eyes for a moment, and I took a deep breath, and I said, you know what, Lord, if this message right now can move through me and into the world to do the work that it has to do, just let that happen. It really was. It wasn't about me, and that's not to say like, oh, but it really, I think for me, when I really focus on the number of people out there in the world, like that woman who stopped me, the woman who was serving the coffee for the CEOs, and stopped me to tell me to keep doing what I'm doing. Like, if I focus on that, if I focus on her, then I feel less scared, and it feels worth it to push forward, to push farther, to push harder, to deal with the resistance, to deal with whatever it is that people are saying can't be done, right? Because I know that if I go that extra mile, what a difference it's going to make for her. And I think that's kind of why we all show up to this work, right? So just tuning into that.
Wow. Humbling, thank you. Thank you for your time this morning, the inspiration, the chance to chat and get some questions and answers, as well as throwing down that gauntlet. ACE is aware, sign up, get it done, let's go people. 500 of us need to be the rest of us pushing it farther, faster and harder. We have a chance to change the next generation. And for that, I thank you. And on behalf of CHCF, we thank you so much, Nadine. Appreciate it.
Oh, it was my pleasure. Thank you so much.